Good morning. Happy Thursday. Thank you all for joining us for another week of data with Dr. Ann. Territorial epidemiologist Dr. Ann Pobutsky is going to be presenting her weekly data analysis in COVID-19 for Guam. Also joining us today is our Chief Public Health Officer, Chima Mbakwem. As you know, this is our weekly presentation of Dr. Ann, as I mentioned, for her weekly
671-4775.
All right. Okay. If you'll kindly just put yourselves on mute. I know some of you are doing live shows right now for your weekly show, or your live radio show. The format of this show is Dr. Ann will go ahead and present her weekly data analysis, and then we'll go to our Q&A section, where we'll do one round of questions for each of our media outlets. If you can go ahead in the chat box, enter your name and the media outlet that you represent. Thank you. And then from there, I'll go ahead and give share screen permission to Dr. Ann so she can go ahead and begin her presentation. Thank you.
Okay, this week's report. Basically, we're continuing to see a slow and steady downward trend in COVID cases, along with the 7-day rolling average. When you see these little blips, that's the weekend, and it always goes up, but the average is right here in orange. And the average weekly cases have dropped by 20 in the past week. We're still around 100 per day on average, which is means we're still in a surge, but it is starting to go down. We're also seeing a steady drop in the number of tests, but we're still averaging around 1,000 per day. So it's following the pattern. All age groups are generally converging in a downward trend. And we still have this group 18 to 39 and 40 to 59 still the highest group, but we also see an uptick in the kids. This is the children 0 to 11, I believe. Yes. And we're seeing a decrease in the 12 to 17 age group. And we think that's because there's more vaccinations in this group, which is really good. And we're on track to start vaccinating the 0 to 11, the 5 to 11 group in November. We're also seeing a decrease in hospitals. This is over the past month, of course. And we've also seen a slight decrease in ICU in the last week, as well as a slowing down of the deaths, which is good. But we're still too high. And except for a couple of these spikes here, the symptomatic cases are averaging around 40% of the cases, and that means 60% are asymptomatic, which is characteristic of Delta. And here, the blue line is our vaccination rate. It's hovering around 82% of the eligible population, but we still see more, so we're still seeing more breakthrough cases, but the unvaccinated are still the majority. And we're probably going to have to change the definition because we started doing booster shots. So we might have to make a redefinition of what a breakthrough case, in case anybody breaks through after a booster, and we haven't seen that yet. And I just want to summarize some other data. People have continually asked about the breakthrough cases, which is, of course, defined as somebody who had an infection after they've been fully vaccinated for at least 2 weeks. Now, continuing to remember this, no vaccine is 100% effective, and we expect breakthrough cases. Some fully vaccinated people will get infected, and some people will be hospitalized or die, and that has happened. But I also want to add a caveat. You know, the CDC does not even count breakthrough cases unless they're hospitalized or fatalities. We are right now compiling the GMH data. As soon as I get their denominator, we should be able to take a look at what's going on in the hospital with vaccinated and unvaccinated. We just got that data last week. I'm asking for the total number so we can compare. But what we do have this week is the rate per thousand population vaccinated of breakthrough cases. And we can see it's similar. So what we have here is it's a ratio times 1,000, which gives us a rate per thousand in the population. And this is the total population vaccinated by brand. You can see there's about 62,000 who had Pfizer and about 2,000 breakthroughs, which gives us 36 per thousand, which is low. Moderna, we're getting 30, J&J 42 with an overall rate of 34.5 per thousand, which is really, really minimal. So that's this week's report. And again, I hope to have hospital data, and we'll look at deaths and hospitalizations and cases on breakthroughs. And then I don't think I need to talk about breakthroughs anymore. Any questions?
I have a question. So my question is,
Sorry,
you said,
sorry, Ceejay, I'm going to go ahead and begin the question and answer portion. I'll call upon you once we get to you.
okay, no problem.
Okay, thank you. We'll begin with Polly Suba from K57. Thank you.
Thank you. I'm not sure if it's Dr. Ann Pobutsky that can answer or Chima Mbakwem, but there are reports with the CDC that PCR tests are not going to be used after December 2021. Are we also going to move away from PCR tests? And if so, what tests will we be using? And why is CDC claiming that we will no longer be using PCR tests after 2021?
I have not heard this. I don't know how to answer that. Chima?
Yeah, I'm hearing this from you for the first time. I wish I know where you got the information from.
I got it from EUA withdrawal for CDC COVID-19 PCR tests due to the development of newer tests that help save time and resources. So according to you now, is you have no word that we're going to discontinue using PCR tests then?
You know, like what you just read out is what is going to happen in the future. And I think there was a press release yesterday that actually talked about the public health, the CDC deployers that are coming to Guam. And part of their mission objective is to guide and support expansion of routine screening and testing and Guam preparedness testing strategy. So that is part of what we're going to discuss with them as they come in soon. So you will have a response when they come in. Thank you.
And then I guess if I can just follow up that with PCR tests, can we clarify the process of what you would like the people to do if they are exposed, so that way you can get a proper testing? As far as, for instance, if my coworker tests positive and then I have been exposed to somebody that gets test positive, what is DPHSS guidance on what I'm supposed to do? Do I instantly isolate for 3 days and then go get tested and then wait for my results? Or do I go to work, wait 3 days and then get tested? Or do I immediately go get tested when I find out that I've been exposed?
Okay, so please, if you can rephrase your question, are you asking in relation to the anticipated stoppage of the PCR testing that you mentioned, or are you asking a question about our process for case investigation or referral for testing, so that I'll be clear on how to answer you?
What is the guidance to the general public when they are exposed to a positive case? What is it that you would like the general public to do from as soon as they get told that they've been exposed to somebody that's positive, all the way to the point of returning back to work?
Okay, so if I'm going to make reference to the the guidance that we have now for the vaccinated and unvaccinated. In a nutshell, if you are exposed to someone who has COVID-19, you are supposed to quarantine, while the person who is the index case is supposed to isolate. Is supposed to isolate. In this situation, if you are unvaccinated, you have to quarantine and go get tested within 5 to 7 days. But if you are vaccinated, you are allowed to go to your normal activities while you continue to wear your mask and keep social distancing, and then get tested within 3 to 5 days. If you're positive, you get into isolation. If you're negative, you continue your normal activities, but continue to wear your mask and keep your social distancing and wash your hands.
Understood. And just so that that I understand, you're saying if you're unvaccinated, unvaccinated has to isolate immediately, wait 3
Quarantine.
days, and then go get tested.
The unvaccinated contact to a positive case would have to quarantine and then go get tested between 5 to 7 days. But for the vaccinated, you can go if you don't have symptoms. So first of all, you are exposed and you don't have symptoms, you can continue your normal activities. But remember, you have to continue your mask wearing, you have to continue social distancing, you have to continue to wash your hands, and then within 3 to 5 days, you have to go get tested. If you test and you're negative, you continue your normal activities, continuing to wear your mask, keep your social distancing, and washing your hands. And then if you're positive, you have to get into isolation until you are cleared from isolation.
Understood. Thank you.
Thank you
Thank
so
you.
much.
Next is Joe Titano from PDN.
Morning, Dr. Ann, Chima, Janela. Promise no breakthrough questions today. One thing that I'm curious about is, that 0 to 11 age group that's now driving our caseload. I think historically it's usually been 18 to 39. But I also know that public health says that we don't have any transmission in the school. So I'm just kind of wondering, do we have any idea at this point what's causing that age group to go up? What are we sort of thinking about?
Household transmission.
Right.
Household transmission. You got to remember, the kids who are 5 to 11 are the kids of those 18 to 59, or the 18 to 49, 18 to 39, and 40 to 59.
All right, I think to add on to what Don is saying, so we're actually seeing cases, within this age group. But what we're trying to say is that we're seeing a lot of, home transmission. We're also seeing school age kids who are getting infected. But there has not been any, identified transmission within the schools that we can call an outbreak. But there has been exposures in school. There have been cases that have been identified in schools. But so the difference here is that there is an ongoing community spread. There are people getting infected in the home, and we're also seeing people getting infected in the school. But within this age, there is no clusters that have been identified recently. But we are practically investigating every case that is within this age. And I think our team is working directly with the point of contacts in these schools, to make sure that we're on all the cases that are identified in those schools. So if there is any information that we need to give out to the public, we'll give it out when it's available. But right now, we're seeing transmission. There are cases that have been identified in schools, but we've not been able to see them as a cluster. But these are independent cases in schools, like household members who get infected, kids that are in the same grade who get infected. But I think as we get more information, we would share with the public. Thank you.
All right, appreciate it. And one question, I know that the FDA just approved the booster shot for Moderna and also for Johnson & Johnson, and also that people can kind of mix and match. This might actually be kind of a question for Janela, but I'm sort of wondering how soon are we going to see that? And is that going to require the vaccine committee to sort of meet, or are we going to start allowing people to get that immediately? And also as a kind of follow on to that, you know, as far as the mixing and matching, should people just take the shot as an option if they have it available to them?
No,
You know, to say they have Moderna or Pfizer.
I think to answer your question, like you described, it's just past FDA, but CDC has not come out with a decision, and we have to wait for the CDC recommendation before we can move on that. Thank you.
Thank you, Joe.
All right, thank you.
Thank you, Chima. Next, we'll go to Ceejay Pilarca with PNC.
All right, so I have, my question is, so you identified that there are lower reports on the weekends for COVID-19. What are variables, lurking or otherwise, that you have identified that may contribute to this trend?
It's just a reporting issue. We report on Monday. The lab doesn't, I believe, do any testing on Sunday.
No, Doc,
So-
we have tests on Sundays. Yes.
So it's
I
a
forgot.
reporting issue. It has nothing to do with a special trend over the weekend. It's just our reporting because some of us want a little bit of time off, even though we don't get it on the weekend.
All right, thank you. And I know you said you didn't want any questions about breakthroughs, but my question is, why is it important that we have the same definition worldwide? Because I think that having, well, what is your take on it?
Well, again, the CDC is not counting breakthrough cases unless they involve hospitalized people or fatalities. The problem with the data that we've been reporting and that everybody's asking about is they want to hear about every single breakthrough case. And it's just, to my mind, getting a bit ridiculous, especially since we have evidence that Delta is here. It's been here for several months. It's a characteristic of Delta to have more breakthrough cases and to have more asymptomatic cases. So we shouldn't even be reporting any of this. We should just be reporting the fatalities and the hospitalizations.
Yes,
Because
but
that's the
that doesn't answer
CDC
my
definition.
question. Yeah, that
What?
doesn't answer my question. My question is, why is it important that we have the same definition as the CDC? Because if on Guam we are reporting, like I know it's a syntax question, but why is it important that if on Guam we define it as literally any time that infections or symptoms occur within a person, why is that problematic in terms of a global, in a global perspective? Because we, of course, we are in a pandemic, it's everywhere. Why is it that this information, this definition must be standardized?
Well, it is a standard definition, but what I'm telling you is that for reporting purposes, the CDC does not want to collect data on all the breakthroughs. They only want to collect data on the serious cases, which would suggest that something else is possibly going on. And as we have observed so far with the deaths, every single person who has been fully vaccinated and died has had multiple severe comorbidities. Okay, so I don't know what the World Health Organization standard is. We're following CDC, and I'm just telling you, since we started vaccinating, there's been an obsession with breakthrough cases. And again, if you can go to that CDC link, you'll see that breakthroughs are expected. No vaccine is 100% effective. And we should be concentrating on those serious fatalities and hospitalizations. Not every single person who was vaccinated and got reinfected or got an infection.
So if the CDC is only recording those breakthroughs, as in the ones that are fatal, why is Guam reporting literally everything? That type of, clearly the definition between Guam and the CDC, I don't care about the World Health Organization, I care about America. Why is there a dissonance between us and them? And how does that affect the people of Guam and public perception?
I think it just, okay, Chima, go ahead.
Okay, I think to chime into, to to answer what your question, you're asking if Dr. Ann is saying that CDC is only reporting breakthrough cases that have fatalities or hospitalization, why is Guam reporting all cases? If that is your question, then I can go ahead and answer you.
That is indeed my question.
That is your question, right?
Yes.
Okay, so I think what Dr. Ann is trying to say is, we're reporting the numbers of breakthrough cases. But by reporting those number of cases, the emphasis is on those cases that end up in hospitalization and mortality, because what CDC is looking at is not the fact that somebody who got vaccinated got infected, because it is standard for people who as Dr. Ann described it, if you have the vaccine, there's a chance that you can be infected. But remember that in describing that, they said that if you are vaccinated, you're going to have less severity. So it did not say you're not going to be infected, but it said it reduces hospitalization and it reduces severity. But for further investigation, the tendency is to look at those breakthrough cases that end up in the hospital to find out why those people ended up in the hospital, and then also for those who died, to dig further to find out what would have caused that situation. So I think it's a balance of, definition, like you said, being able to give out the raw numbers to say 500 people got breakthrough cases, but out of these 500 people, 2% of them were hospitalized. Let us conduct an investigation to understand why that number, got into the hospital. I hope I answered your question.
Yes, thank you.
Thank you.
Thank you, CJ.
It's also been because people have been requesting this, because everybody reads the media and they say, oh, breakthrough cases, and they want to know what that is all about. And I think there's some questions about the vaccines. And this, I think it's a big distraction, especially now that we know this is related to Delta.
I understand that. I understand your frustration, and I understand that Delta has that specific gene that allows for it to be more easily transmissible. But the problem is that by showing your frustration about this, you are, in effect, denying the public this information. And it is the responsibility of public officials, no matter how frustrating it is, no matter how many times you have to reiterate yourself, you are still responsible for reporting this information. I also know that statistically, of course, there are some statistical tests such as Ridge and Lasso that do reduce they do zero out basically the coefficients for some logistical information to make it more accurate. I understand that, but it is really unhelpful for the public for you to showcase hostility and frustration in any topic that you don't want to talk about but must be spoken about. Thank you.
I've been talking about it for weeks. Yes. I've been talking about it for weeks. And the fact of the matter is, we do not have to report it. We only have to report to the CDC on the fatalities and the hospitalizations. It's been requested. And so we have complied.
If I can just add, CJ, the information that we provide, we've actually been very transparent. It's in a JIC release every night. We have our dashboard that's on the DPHSS website. We respond to every media inquiry as much as we can. We appear in radio, television interviews. Anytime we get requests from the media, PNC, PDN, KOAM, the Guam Daily Post, we respond as much as we can. Dr. Ann is probably the most accessible territorial epidemiologist I've ever heard of, Chima Mbakwem. So we're actually very accessible as a public health department. There's actually a balance that we try to make when we provide information, so that the information that we provide doesn't actually harm, because there's an interpretation that you have to give when you give data, so that it's not misused or misinterpreted. And so this is part of the reason why we do this on a weekly basis, so that when we give information such as data, there's also information or interpretation that's provided to the public. And that's part of the reason why we're doing this now. So I just wanted to add that piece to what Dr. Ann was saying as well. All right, we'll move on. So next we'll go to Oya from the Guam Daily Post. Thank you.
Good morning, everyone. I'm not sure who from public health would want to answer this, but there is some concern now about the Delta Plus. And I'm not sure if that's something that we've seen, but it kind of leads to, I raised that issue because we spoke about 2 weeks ago about a genome sequencer so that we can test here on Guam for variants of Delta. Can we get an update on that?
So, Oya, you want an update on the last sequencing results that were reported?
No, just about getting a genome sequencer for Guam. It was something that was mentioned about 2 weeks ago about the possibility of getting one.
Oh,
so that we could test locally.
I think that is a big one because the equipment to do the genome sequencing right now is not something you can just buy off the shelf. So I think even in continental US, everybody is looking up to CDC and a few of the labs that have the capacity to do genome sequencing. But it's actually something we are hoping and looking at, an opportunity to procure it if it's available, and we would really want to have that capacity. But right now, it is a capacity that is not readily available, and we still depend on CDC. And to also answer your questions about the Delta variant, I think what you're trying to describe is it a sublineage of the Delta variant that you are?
Besides the PCR, as of the starting.
Yes, I'm sorry,
January 1st,
PNC. Ceejay, can you please mute yourself?
Why is the CDC saying that? Is it because they're
Ceejay,
faulty?
could you put yourself on mute?
Are there too many false negatives? I don't want to say that because I don't know the answer. I wanted them to say why.
Go ahead, Oya.
Okay, so Oya, so you were asking about the sublineages of the Delta variant. Is that what you're calling the plus?
Yes.
Okay, yes. So the sublineages would actually be seen in the results of the genome sequencing. So that's why we really rely on the genome sequencing. But what you also have to understand about the need for the genome sequencing is that it is after the fact. What it does is that it tells us what happens after the fact. So I think for us moving forward is just continuing to follow the recommendations of public health and the CDC, and to stop new transmissions so that we won't have mutation of the variant. So there are sublineages to almost all the COVID-19 variants. So there's a Delta plus that is a sub which is I think the sublineages of the original Delta variant is what you're calling the plus. So I don't think we've seen I don't think I understand what particular lineage that you are talking about, but the plus means that it is a sublineage of the original Delta variant.
Okay, yeah. So forgive me for my lack of understanding. I just was reading national reports of what's been called or termed Delta plus, and it's been described as a variant. And so that's why I was asking about the genome sequencer, because if we have one, then we'd be more able on our own to test for these variants, and then to plan from a public health perspective on how to respond to them. So that was sort of the basis of my question,
No, thank you. We also send out other specimens for genome sequencing, just not COVID. We also do that for TB. So if there's a chance for us to procure and have that capacity, that I think is welcome, and we really appreciate it. But right now, I don't think it's possible.
Okay, thank you. Now, where everyone's kind of watching the FDA, the council is scheduled to meet on October 26th, I believe, to look at Pfizer's request to approve their vaccine for 5 to 11-year-olds. And then the council, the CDC's council is expected to meet the following week. And from the White House, we're hearing that, they're purchasing and preparing to begin vaccinations as quickly as possible once those approvals are provided. Where is public health with planning? I know that Dr. Leon Guerrero last week was saying that the planning has begun because he would like to ensure that it goes smoothly when the push out begins or the rollout begins. Can we talk about the plan so far?
Yes, there's ongoing planning. Like I literally left the office by I think 10 p.m. yesterday with the planning team. So we're actually planning ahead and looking at all the options that we have for the rollout. So while we are waiting for CDC's recommendation to come out after the meeting, we're also working ahead for plans. We actually did it with the vaccines when it came out in December. I think you could see the plan that we have that actually made us have this high number that we have now. When the boosters came out, we exactly had plans in place. So for the 5 to 11, we're also working ahead to have that plan in place. So there's planning, and we're optimistic that we'll be ready to deploy when that time comes. Thank you.
Has there been discussion with Department of Education and other school systems? As Dr. Leon Guerrero was saying, there's an effort, right, to make sure that to get a count or get a feel at least for how many parents are prepared to have their children vaccinated.
Oh yeah, that is part of the planning process that I just described. That we're in that process, and I think at the end of the day we would have something more concrete to present. But right now we're in that planning stage, and is really ongoing.
Thank you, Oya.
Thank you, Oya.
Next is Jerry Partita with PNC Digital.
Yes, thank you. Dr. Ann, can you confirm one particular statistic in that latest update that says that the 0 to 11 age group is now the highest, now has the highest case rate? And can you comment on that?
That is correct. It's in this past couple days, it's spiked up. So yes, we've seen more cases that are in that 0 to 11 group. It's only been within the past, let's see, since the 17th, 18th. This is through the 18th. It's just been the past 3 days, but it is noticeable. We're just observing it.
Okay, and also your latest report states that with the administration of booster shots, a redefinition of breakthrough cases may need to be made. Why is this so? And can you explain that?
Just that it's possible that someone who was fully vaccinated back in January and February and just got a booster sometime in the next couple months, they may or may not become infected. We don't know. We're gonna watch it. That's all we can do is see what happens, because we really do not know. We hope it doesn't happen. We think the booster is going to protect people even more, especially elderly and people with chronic conditions. So all we can say is that it's possible that somebody might get sick even after having a booster. Although it seems unlikely, but it might happen. So we're going to watch and observe.
Okay, and one last question for Dr. Chima. Back to the preparations for that vaccination, right, of the kids. That is going to be a very hard, very difficult logistical task. can you specify the preparations that the public health is making? Like, there's bound to be a lot of sites that need to be prepared, right, for that? And do you have adequate supply of vaccines? They're even saying that that particular age group might need shorter needles, and stuff like that. So can you be more specific on the preparations? Thank you.
So like you mentioned, the pros for individuals that are within that age, I think the most important thing is parental consent for their kids to be vaccinated. I think that is the only hurdle that we have to cross, for parents to accept the vaccine and for them to allow their kids to get the vaccine, which I think at this point is advisable for. I'm a parent, and there are parents out there who understand fully well that the kids need to be protected. We all have vaccine preventable diseases that the kids are mandated to have, before they go to school. So right now it is the parental consent. I think what Dr. Bob mentioned is for us to start early, to put it out there for parents to have that information about, giving consent for their kids to be vaccinated. But the logistical aspect of vaccines being available, shorter needles, I think we've been going through this since December of this year. And I think the island has gotten used to, the situation. We have the capacity, we have the ability to mobilize to start up vaccine pods, and we're able to, like, using our current vaccine rates, that will tell you how much we're able to mobilize. So the answer to your question would be the ability of the parents to grant consent on time so that we can meet our deadline of, starting as soon as the vaccines are approved, and then being able to do what we're used to doing. Thank you.
Okay, thank you.
Thank you, Jerry. So I will go ahead and provide a copy. That concludes our question and answer portion. But I'll go ahead and.
Excuse me, Janela, I do have a question.
Okay.
Oh, I'm sorry. Did I not go to you? I'm so sorry, Daniel.
That's okay.
I apologize. Go ahead, Daniel.
So my question for today is actually in relation to the CDC that's coming to Guam. And I do have a couple questions. The first is, what prompted for you guys to ask for CDC's help? And at one point in the surge, did we realize that we needed their help?
Okay, I think I can answer to your question. The Guam Department of Public Health and the CDC has a working relationship. This is a partnership that is ongoing. They fund our programs. We have technical support from CDC. So sending deployers to Guam is nothing new, because we work with them remotely, for technical guidance, for support. So them being boots on ground is part of what our working relationship with them and the support that we need. So whenever we need support, we ask for support. So boots on the ground is part of the support that we get. So we have the remote aspect of it, through the Zoom, through emails, and then, providing guidances. But when we need boots on ground, to support our efforts, we reach out to our federal partners. So this is just not CDC. This is about HHS, ASPR, and any other FEMA, any other federal partners that we leverage to support us. Like right now, we have the FEMA team on ground, helping us with our monoclonal treatment. We have the FEMA team on ground that is helping us with the vaccination. So it's an ongoing process for us to, ask for boots on ground or, sort for technical support when and where we need it. So I think that would answer your question.
All right. And when you say deployers, what exactly do you mean, and who are they?
No, deployers are boots on ground. is someone from CDC coming to Guam, to work side by side with our team. So like if in the TB program, we had a CDC public health advisor that worked with the program. We have a CDC PHAP that is in the program. So these are boots on ground, sitting side by side with us, to work rather than working remotely. So that's what the definition is.
Right, and they are coming here to investigate the DOAs, right? Can you explain more on that?
So there's an overall objective, So the mission for this team is to investigate the risk factors of COVID-19 transmission and severe diseases on Guam, and this is despite our high vaccination rates, and also look at our strategies for testing and how to expand our capacity, our surge capacity. And also the primary objective is, like you said, is to conduct an investigation to assess the common characteristics of transmission and severe disease amongst those that were classified as dead on arrival. And I think Dr. Ann made a mention of it too. So it's just taking a deeper dive, to look at what would actually have happened if they had similar comorbidities or there are similarities, in what happened to them. So that is just taking a deeper dive. And this can only be done, working side by side with our team, and then also to analyze data and look at other various risk factors that are in our community. So like I mentioned earlier, it's just that working relationship that we have with them, but now is that someone is coming on island to sit with us and work side by side to take a deeper dive on these cases.
Right, and thank you, Mr. Chima. And is there any word on when they will be coming to Guam? Any date?
Yes, we have a date, but things could change. But we're looking at next week. We expected them to arrive this week, but I got an email saying that they would be deploying on sometime between October, or sometime in October, I think the 29th. So they're supposed to come here on the 29th and then leave when they are done with what they are here to do.
Right, and how many are coming to Guam, if you have that number?
So like I said, already, I think there was a press release yesterday that actually stated a number of people that are already on ground. So we have a lot of support from CDC, HHS that is ongoing. So for this deployment, right now, I know that there are 3 people that are slated to arrive next week. The number might increase, because we are expecting a senior epidemiologist, we are expecting a lab subject matter expert, and also a public health advisor. So the list might grow bigger than this, but right now, we are sure that 3 people are going to be here next week.
All right, thank you so much, Mr. Chima.
Thank you.
Everybody, thank you.
Thank you, Daniel. No other questions? Okay. Again, I apologize, Daniel. I skipped you. All right. Any other questions from our media?
I did want to ask Janela, real quickly, with the increase in cases for children 0 to 11, is there a concern with respect to schools maintaining their face-to-face instruction?
Right now, I think there's really no concern in the sense that I like we stated, the school reopening plan has a layered approach. So there is all those approaches that are put in place for the students to be safe. And like every other thing human, there might be 1 or 2 cases where you see these cases and they are addressed quickly. So I think for now, I think there is no huge concern, because there are still ongoing transmissions in the community. And like Dr. Ann said, there are transmissions at home, and then there are transmissions around the community. So right now, to answer your question, there is no concern. And Dr. Ann stated we just started noticing this increase in the past 3 days, and we're watching it. So if there's anything to be done, we'll be able to do it. But the good thing is that we're watching and we're catching it. Thank you.
Thank you, Chima.
Thank you, Aya.
Thank you.
Right. If I can just ask one more question.
Sure.
So, for the testing kits, will that be coming from DPHSS? For the schools?
Can you repeat? I didn't catch the early part of your question, please.
So for the testing kits for the schools, will that be coming from DPHSS?
Yes.
Because we've gotten word that St. John's and St. Paul's haven't gotten any test kits whatsoever.
Did you ask if they made a formal request to public health?
No, we did not, but we did get word that they have not received any testing kits to test their own students.
So you said it's St. John's and
St.
what
Paul's, yes.
Okay.
St. John's and St. Paul's.
All right, thank you. I would have our team reach out to them, St. Paul's and
We can
St.
look
John.
into it.
Thank you.
All right, thank you, Daniel. Well, if no other questions, that will conclude our question and answer portion. I will go ahead and send the data that Dr. Ann presented today to all of our media partners. I want to thank again everyone here for joining us and asking their questions. And I also want to thank Dr. Ann Pobutsky and Chima Mbakwem. And we will do this again next week. I will send the invitation. I apologize about the link that was sent earlier and for the last minute change in the link. And thank you again for your patience. That'll conclude our press briefing this morning.